This video will demonstrate a wound dressing change for high-output enterocutaneous fistula. This wound management technique has provided skin protection and containment of drainage with comfort and mobility for Doris, this 87-year-old patient, since 2011. Ongoing management of the patient's high-output enterocutaneous fistula is important. During waking hours, we found that with her physician's approval, that consuming a pre-measured packet or when purchased in bulk, a heaping tablespoon of Metamucil mixed in 6 ounces of water every 3 hours, that the fistula output becomes gelled and easier to manage. The gelling also helps the digestion process as some nutrition bypasses the fistula altogether. On occasion when fistula output is runny, additional servings may become necessary. Consume 1 dose of Metamucil dissolved in 6 ounces of water every 3 hours. Supplies needed for dressing change. Sizes and quantities will vary depending on wound fistula size. This is what works for Doris. A small mirror, a package of non-woven 4x4 gauze pads, non-sting barrier wipes, calmoseptine barrier cream, Drawtex, Carafoam, non-latex tape, ABD pad, sanitary pad, Ace brand hot and cold back wrap with additional cloth cover for comfort. This is one item we would not recommend changing. After extensive research and trying different types of bands, the pressure and the size are just right for this process. Calmoseptine skin ointment. Carafoam 5x5 size absorbent foam dressing. Doris uses 1 5x5 square and 1/2 of a 5x5 square. Drawtex hydroconductive wound dressing. Doris uses 3 2-inch squares with a slit cut to the center in each and 1 4-inch long thin strip. Ace brand hot and cold back wrap. Doris made a cover for hers for more comfort. Begin the dressing change. Doris lies on the bed in a semi-reclined position and places the mirror so that she can see the wound fistula area. Remove and discard old dressings. Clean the wound fistula area using the 4x4s. You may also use wet wipes. If the fistula is active and output is runny, wait until output slows or consume a dose of Metamucil and wait for output to gel and slow down. Once the fistula is quiet, wipe the area again to remove as much output as possible. Once the area is cleaned, apply the skin barrier wipe on the skin surrounding the wound fistula. Apply calmoseptine or any other skin ointment to protect the skin surrounding the wound fistula. The ointment is similar to a diaper rash cream as it protects and soothes just the same. After the ointment has been applied, she takes the thin strip of Drawtex and inserts it into the fistula as far as it will go. We also refer to this as a wick stick, as it helps to wick away any output. One by one, she places the 2-inch squares of Drawtex over the Drawtex wick stick, with the wick stick coming through the squares. This is why we cut the slits into the squares. The size of the Drawtex depends on the size of the wound. You will want the Drawtex to lie about 1/2 inch beyond the wound in all directions. With the squares in place, she applies the Curafoam half square to the lower portion of the wound, partially covering the Draw-Tex squares. She then applies the full 5x5 square to completely cover the rest of the dressings. The Curafoam collects any output the fistula may have between dressing changes. Doris prefers to apply non-latex tape as a precautionary measure and to add a sense of security to keep the dressings in place. This step is completely optional. With dressings now taped in place, she places the ABD pad and the sanitary pad over the dressings for additional cushioning. She now wraps the Ace brand hot and cold back wrap around her waist, which gently yet firmly holds the dressings in place. Doris can now get up and move about her daily activities with little concern of output from the fistula. We recommend preparing individually bagged wound care kits that are ready to grab for ease of travel.